It's my great honor and privilege to introduce this year's Meredith E. Drench Lecturers. Before doing so, it's important that I tell you a bit about the person we have to thank for this important annual lecture at Sargent College. Meredith Drench, PhD, PT, established this lectureship as Sargent College's first endowed lecture series. She established it to share and to propagate her passion and belief in the compassionate rehabilitation of the whole person. So I would invite you to take the opportunity at some moment during the next hour or so to reflect on and to appreciate Dr. Drench's vision for this lecture, as this year's speakers are perfect representatives of Dr. Drench's passion and belief. Dr. Drench's work bridged the fields of physical rehabilitation and psychosocial behavioral sciences. Her efforts represented the very best of patient-centered care, even before patient-centered outcomes held such an important focus in healthcare. She was really a healthcare professional ahead of her time. Each year, to honor her pioneering efforts in interprofessional practice and interprofessional education, we host for our students, faculty, and the entire Boston University community a distinguished lecture on the psychosocial aspects of healthcare. One more thing before I introduce our speakers. I want to thank especially our Sargent College Speaker Selection Committee members. I see a few of them here. Jessica Kramer, Lee Marinko, Professor Linda Bandini, they're all professors, and Professor Christine Strand, who have contributed so much of their time and effort to making sure that this evening is informative and influential, as well as personally and professionally inspiring for us all. So thank you, committee members. So now I'm extraordinarily pleased to introduce this year's Drench lecturers, Brian G. Skotko and Melissa Joy Riley. Dr. Skotko is a board-certified medical geneticist and co-director of the Down Syndrome program at Massachusetts General Hospital. He has dedicated his career to children with cognitive and developmental disabilities. In 2001, he co-authored the national award-winning book, Common Threads, Celebrating Life with Down Syndrome, and most recently, Fasten Your Seatbelt, a crash course on Down syndrome for brothers and sisters. Dr. Skotko recently authored major research on how physicians deliver a diagnosis of Down syndrome to new and expectant parents. He's been featured in the Wall Street Journal, the New York Times, the Washington Post, the LA Times, NPR's On Point, and ABC's Good Morning America. He serves on the honorary board of directors for the Massachusetts Down Syndrome Congress and board of directors for the Band of Angels Foundation, as well as the professional advisory committee for the National Center for Prenatal and Postnatal Down Syndrome Resources. He's a graduate of Duke University, Harvard Medical School, and Harvard Kennedy School. Based on his clinical experience, Dr. Skotko works to ensure that every healthcare professional can anticipate medical conditions so that the potential of every person with Down syndrome is maximized. Melissa J. Riley is a motivational speaker, a Special Olympics athlete and global messenger, and a member of the Special Olympics Massachusetts Board of Directors. She works at the Massachusetts State House with Senator Jamie Eldridge and is a classroom assistant at the Learning Program of Boston. She graduated from the Transition Program at Middlesex Community College in 2010. Ms. Riley has been the keynote speaker at many events across the country. In 2013, she represented the United States as an alpine skier at the Special Olympics World Games in Pyeongchang, South Korea. She was also a member of Team USA in 2005 at the World Games in Nagano, Japan, and in May of 2010, Riley was inducted into the Special Olympics Hall of Fame. Ms. Riley's goals are to become as independent as possible, to continue her education and exciting career, and to make a positive impact on the world. Please join me in warmly welcoming this year's honored Meredith E. Drench lecturers, Brian Skotko and Melissa Riley.
Thanks so much, Dean Moore. It's such a pleasure to be here, and particularly a pleasure to be here in a lecture series honoring the legacy of Meredith Drench, of course. I am simply the warm-up act to Melissa Riley, so she's the main event. But I want to say on behalf of both of us, thank you to all of you who provide such great clinical care. There is not a single person with Down syndrome who has not benefited from PT, OT, speech, nutrition, and other healthcare services, and we cannot make sure that their lives are maximized without all of your help. So it's a unique privilege to be here today. And in the next 40 minutes that I have with you together, I thought we'd just take a tour through some of the clinical issues and questions that come up in our Down syndrome clinic that we have at MGH. I have a few disclosures. We're doing some clinical trials from Hoffman-La Roche. We're not going to talk about those today. I'm proud to be able to volunteer for several Down syndrome organizations, and I have two sisters, one of whom pictured there is Kristen, and she has Down syndrome. So the goals I hope we do today is how do we make sure that people with Down syndrome are getting the best medical care? What is the workup for behavioral issues that sometimes go along with Down syndrome? And what are some of the other medical conditions that people with Down syndrome might have? And what are some healthcare resources that we as healthcare professionals have to make sure that people with Down syndrome live the most maximized lives? Where do all these come from? We have a playbook. So the American Academy of Pediatrics developed guidelines that told us these are the basic elements that all people with Down syndrome can and should receive. And we've created parent-friendly guidelines as well. So if you are a parent out there and you go to this website, you could find the age group that your son or daughter belongs to, and you could download these to make sure your primary care doctor is checking off all the major healthcare things that should be done. Now, I want to go through some of the top questions that I get asked in clinic. So prior to people coming to see us in our clinic at MGH, we ask them to fill out an intake form, and we say, mark down the things that you want to go over. So I'm going to go through the top things, and the number one question we get is, my son or daughter is having some behavioral issues. Can you help? And since behaviors are so common and manifest in so many different ways, we've developed a Down syndrome behavior checklist. Sometimes behaviors are the only clues that someone with Down syndrome, someone with that intellectual disability is giving us that there might be a real medical issue. And so in the next slides, we're going to go one by one through some of these medical issues here. Sometimes when we go through there and we've maximized or we have eliminated any of those medical issues, it could be language, the frustration from not being understood. And the third one is we need to think about some other co-occurring behavioral conditions. One of the things I'm a big believer in, it is any of us who are interacting with people with Down syndrome who could be the first to pick these things up. And we all need to be multidisciplinary, interdisciplinary, and interprofessionals, because any of us could be on the front lines and any of us can make these diagnoses. So whether you are going into PT, OT, speech, or nutrition, I hope you'll be able to also keep some of these things in mind as we make diagnoses together. Hearing challenges goes along with Down syndrome. Up to 75% of people with Down syndrome will have hearing loss at one point in their lives. And it could be conductive hearing loss, which is common in young kids. It could be sensory neural hearing loss, or it could be a mixed hearing loss. The reason why we like to identify that so early is if you can't hear, it's going to make speaking even more challenging. And of course, from learning point of view, we want to make sure all the good skills are taken in the classroom. So many things that we could do here. Those ear canals are so small in people with Down syndrome, we oftentimes need to put the tubes in. And sensory neural hearing loss, of course, could be amplified with an FM amplification system and hearing aids. Vision difficulties go along with the show as well. 3 out of every 5 will have, and you can see they could be nearsighted, farsighted, having astigmatism. Nystagmus can mean other medical conditions that need to be worked up, the shaking of the eyes. Strabismus, where you have one eye that has strong eye muscles and the other eye that has weaker eye muscles. We could strengthen some of those muscles if identified early. Cataracts could be present in young kids with Down syndrome and adults with Down syndrome. We're always looking for that because treatment is available. And sometimes people with Down syndrome, their tear ducts get clogged up. And we need those eyes to be lubricated. So sometimes we need to open those tear ducts up. Thyroid is a hormone that we all have that's so important, not only for cognition, but for the regulation of our bowel habits and also for our temperature regulation. If someone with Down syndrome feels tired, sluggish, has constipation, feels unusually cold, or just the opposite, they're hyperactive, they're restless, they have diarrhea, sweating, or behavioral problems, it could be because their thyroid is off. And because almost everyone with Down syndrome has one of these symptoms at every single day, we're kind of left with how often should we be drawing thyroid levels. Right now, the best evidence suggests we should draw them at birth, 6 months, 12 months, and then every year for the rest of their lives, because the thyroid could be off at any point throughout their lives. If you have too little thyroid, no big deal. We can add it back with levothyroxine or Synthroid. If you have too much, there's medications we could use in order to sponge it up, or sometimes surgery is needed. And then there's this third case where a signal from the brain is too high, but the thyroid gland is producing the right amount. In this case, we follow them closely and we'll even initiate thyroid medications a little bit early. Again, something that's easy to notice, but if you're noticing one of your clients, one of your patients with Down syndrome is unusually slow or having difficulty learning things, it's entirely appropriate to say, when was the last thyroid checked? And if it's more than 12 months, this can make a big difference. And it's amazing how much our bodies change when we don't have enough thyroid. Celiac disease. You might have heard of people being on a gluten-free diet. Celiac disease goes along with about 5% of people with Down syndrome. And again, if they have diarrhea, constipation, bloating, GI symptoms, we're definitely going to test for celiac. But usually the first sign of celiac is behavioral issues. And that's because the stomach just quite isn't feeling right over time. Don't quite know how to articulate that feeling that builds up, so you manifest with some new behavioral problems. When I see children with any of these symptoms or behavioral issues, we're going to go looking. We start with a blood screening test. It's not perfect, but if it comes back positive, then we're going to go work with our GI doctors to get a biopsy of the small intestine. If that biopsy comes back and it indicates celiac by looking under the microscope, then we're able to start on a gluten-free diet. Many of you might know that having celiac isn't necessarily that hard. My wife has celiac, and so by proxy, I'm on a gluten-free diet. And it's amazing how much the restaurants and the health food stores and our grocery stores really have expanded the options for people being on a gluten-free diet. But, as many of you know in nutritional services, just because it's gluten-free doesn't mean it's good for you, right? Just because a brownie and a cupcake and a cake is gluten-free doesn't mean it has good nutritional value. So we've seen a lot of our patients with Down syndrome who have celiac actually become overweight and obese because they eat anything that's labeled gluten-free. So we have to also teach good nutritional skills. I just want to take a quick pause. Many of you might remember Dr. Alan Crocker, who was a mentor to me and who passed away several years ago. In order to honor his legacy in one of many ways, at Boston Children's Hospital, when I was there, we created a lecture series in his name. The reason why I bring this up is so many of us are seeing our clients or our patients with Down syndrome, and we don't have time to launch into everything. So every little slide I have has its own 30 to 40-minute speech here for parents and parent language. So if you want a whole lecture just on thyroid and Down syndrome, go there. There's one for that. If you want one on celiac and Down syndrome, there's one on that. If you want one on toilet training and Down syndrome, there's one on that. So it's a great webpage that I like to send parents to go for free webinars that they could watch at any time. All right, back to the workup on behavioral issues. People with Down syndrome, I am convinced, are constipated until proven otherwise. They really just pack stool in there. And I always like to talk to parents when they have a younger child, make sure you develop good, healthy bowel habits, because as they become adolescents and adults, you're not going to be watching them, and it's really up to them to know that they need to have a bowel habit every day. This is a patient of mine who came to me when she was about 8 or 9 years old, and the school was complaining to mother that her behaviors were erratic. Mom was saying, I'm noticing it at home. They did the sticker charts, they did the positive reinforcements, they were trying everything, and she was just irritable all the time. So she comes to see me and we're working our way through the behavior checklist, right? So I always ask parents, how often does your son or daughter with Down syndrome have a bowel movement? And unless I hear, oh, I know every day they're having a bowel movement, then I go for an x-ray, because people with Down syndrome can't always tell us what it feels like to be constipated, that feeling that kind of builds up over time. So those of you who don't read x-rays on a regular basis, black is air, white is bone. So here are our lungs up here, and you see black up there. Here, white is the bone, so here's our vertebra here, here's our hips here. So our colon, if it didn't have anything in it, would be full of air, right? If it had stuff in it, it'd be opaque. So here is the rectum here, and then we're going to start to do the colon just like this. So here are big stool balls here. Here, it's so white, it's just packed with stool, and you can see speculated stool all the way down here. This is an entire abdomen full of stool. This hurts, right? And it hurts over time. But fortunately, we gave her a makeover. Isn't she beautiful? This is the best I could do as a geneticist, right? So we gave her some stool softeners, and now all the speculated stool air balls, look at those big air balls here. This is just a cleaned out colon, and I've never seen anything more beautiful. So what we do is we send them back to school, and we don't say that we've changed anything, and within a matter of 3 to 4 days, the teacher started writing the mother and said, oh my goodness, she's back. What psych medicines did you put her on? And we said we put her on a stool softener. That's all we needed to do. So you could bulk it up, you could soften it down, you could squeeze it out, you could slide it down, or you could water it down. Yes, after all those years of education, I became an expert in stool. But sometimes this is the biggest thing that can make a difference, and people with Down syndrome need a combination. Every year I have people with Down syndrome that are so impacted they need to get a colonoscopy clean out at home, which I concoct. Sometimes that does not work. I need to admit them to the hospital. I stick a nasogastric tube from their nose to their stomach and pump them with liquid in order to get it out. Sometimes that doesn't work and they need to go to surgery to get it surgically removed. It doesn't need to get to that point, and this is why for all of our friends and family members and patients with Down syndrome, we need to teach important good bowel habits at a young age. You know, when people come to see me, they fill out that intake form and they send me invitations to birthday parties and bar mitzvahs and all sorts of wonderful things, but every once in a while I get a photo. And this was a photo from a mother who said, "This is what you're getting, just to warn you." But sometimes a photo is worth 1,000 words, and we know, don't we, instantly what this child has. This child actually has a very serious medical condition. You see it? Let's zoom in. Boom, right? Those are big whopping tonsils. There is no oxygen getting back there when this child is sleeping. This child has severe obstructive sleep apnea. Obstructive sleep apnea goes along with Down syndrome. 3 out of every 4 people with Down syndrome will have it at one point in their lives. What is obstructive sleep apnea? It looks like you're sleeping at night, but not enough oxygen is getting there. Your chest are rising, you're sleeping 8 hours, but oxygen is not enough is getting in there. If you don't get good oxygenated sleep for any of us, what happens? You feel tired, you feel foggy, and then if you still don't treat it, it leads to anxiety, leads to behavioral issues, leads to heart issues, diabetes, hypertension, and also new valve issues in the heart, right? If someone with Down syndrome says yes to any of these questions, they snore at night, they gasp or choke, they're falling asleep. If you have an 8-year-old with Down syndrome and she's like, "Oh yeah, she always falls asleep in the car, it's so easy, we could drive anywhere." No, 8-year-olds should be up all day. Right? They shouldn't have to fall asleep in cars. This could be a telltale sign. Napping. After you're the age where you shouldn't be napping, you shouldn't be napping, right? And that could be a sign of apnea if they don't seem refreshed. If you have a client or a patient and they're at 3 o'clock, 4 o'clock, and they're falling asleep, this is an indication. It might not just be they had a tough day. It could be they had a tough day and they also have obstructive sleep apnea. Here's the challenge. The majority of obstructive sleep apnea is silent in people with Down syndrome. It doesn't give us any single clue. They'll answer no to all of this and they'll have severe obstructive sleep apnea. As a result, the recommendation is everyone with Down syndrome gets a sleep study by the age of 4. If they're older and they've never had a sleep study, we get them caught up as soon as possible because we're picking up all this silent sleep apnea. How do we do that? We get a sleep study, also called a polysomnogram. It's the only way to do this. It's an intolerable test for many people with Down syndrome. I wish I had a better way, but I don't. If it is big, the first step is to get the obstruction out. In most of the cases, that's the tonsils and the adenoids, right? This is a sleep study. This is my patient Julia, whose mother gave me permission to use her photo. You can see how delighted she is to be getting her sleep study. They have to sleep on their back. Yes, we kind of strap them in. We have wires all over the places. For people with Down syndrome who have sensory integrative disorders, you can imagine how fun this night is. But we do our best. You bring your baby doll, and we have our baby doll going through the process, right? And then we also create a handout, parent-to-parent advice on how to get through a sleep study. We also create a handout on the importance of a sleep study so parents realize this is not something that you kind of blow off. We really want to get this done together. If we go and we find obstructive sleep apnea and we get the tonsils and adenoids out and there's still obstructive sleep apnea or it comes back, as it did for my sister with Down syndrome, she had her tonsils and adenoids removed, 10 years later, sleep apnea back, then one of the next steps we have to go for is a CPAP mask. This is a mask that's worn at night that really pushes the oxygen in to get past the obstruction. Many people with Down syndrome can tolerate this. Some have a lot of difficulty getting there. And as you can imagine, working with those with sensory integrative disorders takes a while to get them desensitized to this mask. But we do our best. And we had a student who rotated through our program who was a great cartoonist, and she created this cartoon book for us. You know, scuba divers wear masks, astronauts wear masks, firefighters wear masks. Now you get to wear a mask too. Isn't that so cool? Some of them you could trick with that, some of them you can't, right? So they could color it in, but it just goes to show the creativity that we could have in terms of making sure that we're trying to make it cool. Then you see your patients and you're like, this is not working. And I would just continue to remind all of us, if we see things that are not working, try to look for alternative solutions. Those of us at MGH read about this study that became available for all of us, quote, neurotypical adults. So if you were to have obstructive sleep apnea and you didn't want to wear your CPAP mask, then you could get this new device that's FDA approved, and I'm going to tell you about it. Now, for the first time on a research basis, we're offering it to people with Down syndrome. Here's how it works. You have a little pacemaker that's implanted underneath your skin, little battery pack. Underneath your skin, you have a little wire, and this probe is connected to your lungs, and you have another wire that's all under the skin that's connected to the hypoglossal nerve, which is the motor nerve that stimulates the tongue. You have that implanted. After it's implanted, then you're ready to go to bed, and you have a remote control. And either the person with Down syndrome or the parent pushes the remote control that's timed for 15 minutes, 20 minutes, 30 minutes, timed after the person with Down syndrome falls asleep. The person with Down syndrome then falls asleep, and the battery goes on. Every time the lead from your lung says, time to breathe, it tells your tongue muscle, move it. And so your tongue muscle goes. So the entire night, you're kind of sticking your tongue out a little bit. You get the big tongue out of the place, enough space for the oxygen to get in. People with Down syndrome, their obstructive sleep apnea, completely cured by just the press of this button. What does it feel like if you wake up? It feels like your tongue's moving. Then you press the remote control, and it stops completely, right? We have gone from people with Down syndrome who were trach dependent, so they needed to have a hole through their neck in order to breathe with severe obstructive sleep apnea, to having that completely patched up, no CPAP needed. All they need is to push this remote control at night. And this really took the ingenuity of reading the research papers, seeing what's out there, and saying, you know what, this could work for people with Down syndrome. And right now we've offered it to 7 people with Down syndrome so far through our colleagues at Mass Eye and Ear. All right, so we're in clinic and we're going through the behavioral workup, right? And we've gone through all of these things, and let's say the person with Down syndrome is still having behavioral issues. Sometimes it could be expressive language skills, and all of those who are in training to become speech and language pathologists, and those of you who are SLPs, thank you. Because people with Down syndrome get frustrated when the rest of the world can't always understand what they have to say. So at a very early age, we start to recommend forms of alternative and augmentative communication. Sign language and sign gestures really go a long way. Signing Times program is a fun video, rhyming, song-singing way of teaching sign language for the entire family, which really helps. As they get older, we start to promote alternative augmentative communication. This is just one of many. So Proloquo is a program that can be downloaded onto your iPhones or your iPads. When you're with someone and they don't understand what you have to say, then you can pull out your backup device, you touch the little symbols, and then I'll say, hey dude, I want to play baseball. Okay, well, on recess today, we're actually going to play kickball. We can't play baseball. No, I want to play baseball. Okay, why don't we play baseball tomorrow and we'll play kickball today? Okay, dude, right? And what they just had on the playground when we weren't there to be translators, they had a normal bro-bro conversation, right, in grade school, and we've avoided the meltdown, we avoided the smacking, we avoided any of the things that would come from frustration. I oftentimes hear from parents, but I don't want my kid talking with the device. I want them to use their words. I want them to use their words too, and you know what? They want to use their words too. All the research demonstrates that words are faster, and when given the choice, they're going to try their words first. But if their words are not being understood, we either leave them with nothing, or we give them a backup device. So I really kind of consider these human rights issues and making sure that people with Down syndrome have their backup device. But if you have an iPad that has one of these programs on it that also has Angry Birds and lots of games, guess what the person with Down syndrome is going to use it for? The games. And these parents will then come back saying, it doesn't work, right? So we really find for it to be working for people with Down syndrome, it needs to be stripped of all other games and used really as an extension of your voice. What I also tell parents is wherever your voice goes, the backup device got to go. So it's not like you only have this when you're in school or you only have it when you're in your speech and language session. It goes with you at home. It goes with you to grandma's. It goes with you to church. And if in the middle of church, during the middle of the homily, your son or daughter pushes that device and says something out loud, secretly inside you should be cheering, yes, my kid spoke out loud at the most inappropriate time, right? But when you get home, you have a wonderful opportunity to teach a lesson saying, I'm so glad you used your voice, but you didn't use it at the right time, and that really disrupted church. So it needs to go with them, and they need to use it in all the appropriate and inappropriate ways as though they would be using their voices. We like to recommend books as much as we like to recommend stool softeners in our clinic. And so these are just two of the many books that are out there. Many of you know Woodbine House has a great set of literature for people with Down syndrome, and we like to recommend them. All right, they're still having behavioral issues. We've worked through 1 and 2. Behavioral issues are still there. Our thesis in our clinic, it's not just Down syndrome until we think about everything else. We no longer accept the premise, oh, that's the way those kids are. Oh, that's the way people with Down syndrome are. Maybe it's Down syndrome and ADHD, which goes along with the show. People with Down syndrome have inattention in more than 2 settings. They can and do deserve to benefit from ADHD medications just like everyone else. OCD definitely goes along. Many people with Down syndrome are among the neatest and most orderly in their family. But my sister one day, when she grew up, the obsessions and the compulsions turned into a disorder. In her first job, she worked so hard to get, she was so concerned about whether or not her purse was being zipped up that she couldn't focus on her task. So then my mother said, you can't take the purse to school. And then she was worried about your purse being zipped up and your purse being zipped up and your purse being zipped up. Her brain was telling her the zippers needed to be zipped to the point where they fired her. There was no amount of accommodation that they could afford her to stay in that job. It wasn't until she found a psychiatrist who gave her psychopharmacology that she deserved that we calmed down those neurochemicals, we calmed down the disorder part, and she was then able to return to employment that she wanted and she deserved. So it can be very real for people with Down syndrome. Depression and anxiety go along for all of us, but people with Down syndrome sometimes, not always, get stuck. I had a patient of mine who was about 14 years old and came to me in clinic, and the mother's like, she's just not herself, and she was listless. So I'm going to make up her name, Megan. How was your day at school? Who are your friends? So what do you do for fun? And the mom would put out a cell phone and she said, you know, we have videos from like 8 or 9 years ago, and look at, she was the most talkative person. She was a bully, and just slowly over time, she's disappearing. She has no excitement anymore. So we're going through all this, going through the checkups. It's not thyroid, it's not celiac, it's not all this. And so after several sessions, we said, well, when she does talk, is there anything she brings up? And after going through this, mom's like, well, every once in a while she talks about my mother, her grandmother. And I said, oh, well, tell me a little bit about your mother, your grandma. Oh, she died like 8 years ago. But when we probed, this person with Down syndrome was still mourning grandma's death as though it was yesterday, right? Sometimes they mourn and they get stuck. We're all sad when grandma dies, but usually around 6 to 9 months, we're able to honor grandma's legacy and move on. Some people with Down syndrome can't move on, and we find at major life events, sometimes they get stuck. And that could be a divorce, it could be moving into a new house, it could be a brother or sister moving away to college, right? All of these things are naturally occurring events that sometimes we can't change the force of, but it's important to recognize that these could be particularly traumatic, and help is there. So if we recognize and we get someone with Down syndrome in to see treatment, with the right treatment, we could get them out of it. And sometimes they only need treatment temporarily. Autism spectrum disorder can also co-occur with Down syndrome. If you have a client or a patient with Down syndrome who also has significant communication difficulties, typically these will be the people with Down syndrome who are nonverbal. In addition to repetitive behaviors, sometimes it's twirling, sometimes it's flapping, sometimes it's stimming in a way, and significant difficulties with social skills. The usual person with Down syndrome, very social, coming up to you, making eye contact, shaking your hand, wanting to give you a hug, however inappropriate, right? The person with Down syndrome and autism would rather be alone, right? They're not going to look with you in the eye. They're going to prefer to be alone. They're going to be the person, rather than playing with the group, is going to engage in parallel play. If you have a lot of difficulty getting eye contact with the person with Down syndrome, you're noticing that they're having stimming, you notice that they're having difficulty with communication skills, perhaps it's Down syndrome and autism. And I'm not about diagnosing just to have another label, but an appropriate diagnosis really unlocks a lot of other therapies. And many of you know that discrete trial training or applied behavioral analysis, ABA here, when dosed at 25 hours or more, can really make a dramatic difference for people with autism and people with Down syndrome and autism. And many schools here in Massachusetts will not give you that therapy unless you also have a diagnosis of autism. So it makes a difference. And as a geneticist, we are now able to come up with a cause or a reason for autism about 30 to 40% of the time. And people with Down syndrome who also have autism also could benefit from this workup. So perhaps it's Down syndrome and a microdeletion, or Down syndrome and Fragile X, or Down syndrome and a metabolic condition. And finding another answer comes with another playbook sometimes, and other therapies and potentials. So really getting the right diagnosis makes a difference. All right, that was the first concern you had when you came to clinic. My child has behavioral issues, so we kind of went through that. Now in a little bit more of a rapid format, I want to go through some of the other things that come up in clinic and just briefly how we kind of handle them. One, we have many parents who are concerned about their sons and daughters' weight, and I'm certainly glad that they are. People with Down syndrome, particularly as they get older, have a lower metabolic rate and therefore are more prone to becoming overweight or becoming obese. And last year, the American Academy of Pediatrics, in addition to a grant, came out with new growth curves for people with Down syndrome, which replaced the ones from 1988, which are terrific. It's great to have updated growth curves, but they sampled the modern day person with Down syndrome. And the modern day person with Down syndrome is usually overweight and obese. So if I plot someone's weight on the new growth curves and their 50th percentile for their age on people with Down syndrome, everyone gets excited. Oh, they're nice 50th percentile, but the 50th percentile is overweight and obese, right? So we're not going to jump up and down and say, congratulations, you're 50th percentile. So what do we do with these? Well, I don't know. So we kind of use these. I use the typical growth curves, and I increasingly go back to the BMI or the weight versus length growth curves because it's a combination of both. So I'm glad that we have these, but I don't think we should rely on these because they could give this false reassurance, particularly when we look at the weight curves. So we try to really educate our parents on the functionalities and the limitations of these. This is just one little snapshot at patients that we saw in our clinic. Of all of the patients ages 2 to 19 in our clinic, 61% were overweight or obese, and in comparison to the neurotypical population, that's 32%, so almost doubling. And granted, we have a referred population to our clinic. In our adults ages 20 to 60, 80% are overweight, and the typical population is about 69%. Right? So we really tried to address it in our clinic and come up. Those of you who are engaged in physical therapy and occupational therapy, many times you're thinking about, oh, there's something with the neck in people with Down syndrome that we have to be cautious for. So let's break it down together. Atlantoaxial instability or occipital axial instability kind of comes up with Down syndrome. About 15% of people with Down syndrome fall into this category. Let's go to our anatomy. So in our vertebra, our first vertebra is called C1 or the atlas. Our second one is called the C2 or the axis, connected by this odontoid dens. Our spinal cord runs in the middle of the spinal canal. This odontoid and dens is kind of tethered, if you will, to that bone by some ligaments. But if that ligament is a little bit loosey-goosey, which it oftentimes is in people with Down syndrome, that odontoid dens is going to kind of nick forward and start to touch that spinal cord. It starts to touch that spinal cord, that's when we start to have some neurological conditions, right? So how does all this work? We used to get neck x-rays, but the neck x-rays don't predict who's going to develop AAI or not. So if I have a normal neck x-ray, tomorrow it cannot be normal, or the following day it cannot be normal. So therefore, neck x-rays really aren't clinically indicated for an asymptomatic patient, right? However, Special Olympics is still requiring neck x-rays for legal purposes, so we have to get them anyway, right? But when do we need to look out for this? These are the symptoms I think all of us clinicians need to look out for. If the patient with Down syndrome is all of a sudden starting to walk differently, is that spinal canal being touched? Is it starting to develop symptomatic AAI? If they're starting to not use one of their extremities in a way, if anything with the neck stiffness, neck pain, neck tilt, neck anything that you're noticing that is sustained, we really want to go start looking. If their reflexes are starting to be great, or if all of a sudden they're losing continence where they had it before because those nerves from the spinal cord are being tapped and they're not innervating the bladder or the colon correctly. What do? Then we get the neck x-ray. We're not going to get one view, we're going to get 1, 2, and 3 views in 3 different views. We have to make sure we have an expert pediatric radiologist who knows how to place those little markers there. We're measuring, again, that odontoid and the dens attached to C1. And if it's greater than 4.5 millimeters, and this is why we need a great radiologist, because if they place it off, we're just going to have a false reading. If it's greater than 4.5 millimeters, it means that they're prone to having atlantoaxial instability, and we start to restrict those sports that have rapid movement of the neck. And typically those will be some contact sports, gymnastics with the tumbling, horseback riding, where you're bouncing up and down, diving, being on a trampoline, and during anesthesia, you have to be careful when you intubate. So to sum it together, if you have an asymptomatic patient, none of those conditions whatsoever, they don't need neck x-rays, they can do whatever they want. If they're starting to become, unless they're in Special Olympics, then we need to get it anyway, right? If they're symptomatic, then we're going to get a neck x-ray. If it's less than 4.5 millimeters, false call, they could do whatever they want. If it's greater than 4.5 millimeters, we're going to restrict activity. If it's really great, sometimes our orthopedic surgeons need to go in and bolt those two vertebrae together. Once a year, we hear about someone with Down syndrome who becomes paralyzed because of this, but I'm here to say paralysis does not happen overnight. In those cases, when we look back, there were symptoms for 6, 7, 8 months, and no one picked up on them. That's why I think it's so important for all of us to know these symptoms. All right, what about shaking movements? Seizures can go along with Down syndrome. Down syndrome-specific seizures happen before the age of 1 and again after the age of 30. And I want to show you what an infantile spasm looks like. This is one of my patients whose mother sent me the following video. So these are all normal baby movements. Mom was very kind of perceptive. That little arm shake right there, is that normal or is that a seizure? That actually was a seizure. And Mom was good enough to kind of know that that movement was different. That this is all normal baby movement. Normal baby, loving his toes, looking, having fun. That right there, that arm, Mom didn't like it. That was a seizure. And this mom was very good at picking up a seizure. She brought Benji in, who was started on medications, but I want you to see how the seizures start to evolve very quickly. And this is what Benji looked like about a week and a half later.
Hey Benji, it's okay, honey. It's all right.
Boom.
Oh, honey.
I'm not sure why the video flipped, but we'll go with it.
Okay.
So you see these jackknifing of the arms and legs, if you could see sideways. And you see a kind of a grimace on Benji's face. It's not because it's painful, it's just kind of shocking that something just happened. And these are kind of cluster seizures that are happening right now. Oftentimes they'll happen after waking up.
Nap like 20 minutes ago, and all of a sudden he's doing this.
It's important with seizures like this to be recognized early, to go to medical attention so we could try to abort those seizures with medications. If the seizures go on too long and are untreated, it can lead to lifelong consequences for people with Down syndrome. And it could take any of us to pick up on this. And that's why I'm so passionate about educating parents, because we don't need and we don't want to wait until the next pediatrician's appointment 2 to 4 months from now, because it's going to be too late by that time. So we create lots of fact sheets, and every patient who comes to our clinic gets the infantile spasms fact sheet when they're under the age of 1, and it has links on there. I have parents go watch videos so they know what to look for. So parents like Benji's mom were so able to pick this up. What about limping and leg pain? If you're in your PT session, is someone starting to limp where they haven't before? 2 things we need to keep in mind. Hip dysplasia or dislocation. 4% of people with Down syndrome will have it. We want to make sure we get good x-rays. It's not going to go away on its own, and we need to get surgery and immobilization. Let's talk about leukemia. So people think leukemia and Down syndrome, but 99% of people with Down syndrome do not develop leukemia. 1% do. And if they do, they're not alone, and we're there to take the journey with them. But usually the presenting symptom is a limp. Why? Because leukemia is a bone pain, and they feel it in their bone, and it's a limp. This is a baby white blood cell that doesn't know how to grow up. This is a blast. This is leukemia. There's 2 types of leukemia in people with Down syndrome as children, and there's chemotherapy regimens that are available. Just a little bit about Down syndrome specialty clinics. There's 58 of us who do these Down syndrome specialty clinics in 32 different states. We're fortunate enough to have 3 in the state of Massachusetts, at UMass Worcester, at Boston Children's Hospital, and at MGH. Just to tell you a little bit about my program, these are the incredible people that I get to go to work with every day. It hardly seems like work. There's 4 of us physicians who take care of people with Down syndrome. Allie and I are the co-directors. Allie sees adults and children. I see up to the age of 21. Jessica and Jose see adults. Jessica has an aunt with Down syndrome. Jose has a sister with Down syndrome. Of course, I have a sister with Down syndrome too. So definitely it brings us to it, but not a requirement to be a healthcare professional in our clinic. Anyone who comes to us will be seen by all 4 of these individuals here. Scott Newland's fiance's brother has Down syndrome. He coordinates the whole visit. He's the person that you call. He makes sure that people are going into the right rooms and your visits are coordinated. Helen is our social worker. She had a sister with Down syndrome. She makes sure that you need to talk to this mother. You need to go to this workshop. This is the book that you need to read. Caitlin is our nutritionist. Sees all of our patients with Down syndrome. She has an aunt and an uncle with Down syndrome. Ben, of course, has Down syndrome. He's our self-advocate. He meets with everyone in clinic, and he's our secret weapon. So when I make a diagnosis of obstructive sleep apnea, Ben will talk to them about what it's like to wear a CPAP mask, because he does. If I make a diagnosis of celiac disease, he'll have a whole talk about gluten-free foods because he has celiac disease. If we talk about hearing loss, no problem. He wears hearing aids, he'll talk about it, right? He has a little talk about his girlfriend, a talk about moving out of the house and living on his own. So Ben really is our secret weapon in our clinic. We have 5 sub-clinics within our program. We have a prenatal clinic for those who are expectant and trying to make a pregnancy decision, so they come to us in a confidential way to learn more about Down syndrome. In our infant and toddler clinic, this is an all-day clinic. We don't do primary care. Everyone has a primary care doctor. We simply do the Down syndrome tune-up. You know, I need someone to take care of the other 46 chromosomes. I will tune up the extra one. But I don't do it alone. And in this all-day, people will come and they'll see our core group here. They'll also get their hearing checks, their eyes checked. They'll see one of our physical therapists, occupational therapists, and speech therapists. They'll see a dentist, and if they want, they'll see a feeding therapist, right? If they're like, I already have an ophthalmologist, then they can a la carte out of that. But what we hope to do is rather than having 8 different visits that parents need to make, we can consolidate it all into one. And we offer this program every 6 months for people. And just so you could see, the program is not possible without physical therapists, occupational therapists, and speech therapists. When they become child age, we start to trim what everyone gets. So they still see audiologists, ophthalmologists, dentists, and we start to incorporate a psychologist because all those behavioral issues that start to emerge and some of the school issues that emerge, we get that in. Our adolescent and our young adult clinic, we start to incorporate our neuropsychologist, and we also have a psychiatrist who's available to do that psychopharm for the patients with Down syndrome who do deserve it. And these are some of our neuropsychologists there. When we make brilliant recommendations and we give them to families and they take them to the school system and the school system for whatever reason doesn't incorporate our recommendations, then we have Gretchen available for our patients, and she's an educational advocate. So Gretchen goes in on behalf of our clinic, and she's there to make sure those changes happen. So Gretchen is a benevolent pit bull, and she's terrific at getting that. And it's a service that we're able to give the families that we see because of philanthropy. There's one family who believes strongly in making this available. In our adult clinic, where we're seeing adults with Down syndrome, and we're also doing workup for dementia or Alzheimer's disease in some of our adults with Down syndrome. This is our cast and crew here, and just to show, this is our psychiatrist, Dr. Palumbo, who sees our patients, and just to show that PTOT and speech doesn't end after you turn an adult, we actually have Maggie, who's involved, who's a speech and language pathologist, continuing to work with our adults with Down syndrome who seek her help for a variety of reasons, ultimately fluency and articulation. We also do research, trying to make tomorrow a little bit better than it is today. And Alex Barrasso is my clinical research coordinator who's helping with our clinical trials. All this information is available on our webpage. And since it's 2016, you're supposed to be on Facebook, which we are as well. Anyone can be our friend, and we try to post healthcare information there for people to be there. And we tweet as well. And so many ways that we could stay in touch. And I hope we do stay in touch. You know, I think to practice medicine and practice the healthcare that we want, and it's so hard to do it alone. It's only kind of combined, no matter what college or hospital we're at, that we make it possible. I also want to mention, if you are a student and you want to observe one day, we love to have students. We reserve, every clinic has 1 slot for a student. So if you're interested, just contact me later and be happy to get you through that process. So I promised that I was the warm-up act to the main speaker. And please join me in introducing our main speaker, and that is Melissa Riley, here to tell you about what real life is like with Down syndrome. Melissa, come on up. You bet. And our colleague here is going to get your slides.
Okay, cool. Excuse me. Excuse me. Thank you, Brian. Thank you, Brian, and thank you, Dean Moore, for inviting me to talk about my life with Down syndrome. I am really happy to be here, but I'm also a little nervous. I have a question. Can you all understand me? Great. Thank you. Hi, I am Melissa. I live in Boxborough, Massachusetts. I'm a graduate at the Acton Boxborough High School and of the Middlesex Community College Transition Program. And I love American Idol and Dancing with the Stars, movies, musicals, pizza, sushi, and Dunkin'. Yes. The Boston Pops, the Red Sox, and the Patriots. Excuse me. You see, I am pretty much a regular girl who just happens to have Down syndrome. And honestly, my life is pretty good. In fact, life for all people with Down syndrome is so much better than it used to be. Today, kids with Down syndrome are living at home. They are part of their community. They can go to their local schools. And they are getting a better education, which means better jobs. So, now I'll take a minute to tell you a little bit about myself. And at the end, I'll show you some slides. Okay? Excuse me. It also, by the way, I do know that having an extra chromosome makes me, in some ways, just a little different from you. It also means that learning most new things takes me a little longer, but not for this. And that speaking clearly is sometimes still really hard. But for the most part, I am just a girl who's more alike than different from you. That's why, after high school, just like most of my classmates, I wanted to go to college, too. Live away from home, and then maybe get a dream job. Well, I'm sad to say that living away from home did not happen because I went to a community college nearby. I learned many office skills like word processing, data entry, and keyboarding. After 2 years, I graduated from the transition program with a certificate in business and office support. Oh, a minute. Yeah. But guess what? I did get my dream job. I am working in Boston in the State House. I am an office aide for Senator Jamie Eldridge. I love my job. And my co-workers are all super nice. And I have the best boss. Really, it's true. I'm also a classroom assistant at the Learning Program of Boston. This is a school where very young children with Down syndrome, together with their parents, learn reading and math skills, and we prepare them for regular kindergarten. Next, I'm going to tell you a little bit what I do in my free time, okay? I love to go out and do things with my friends and family, like going to movies, air shopping. I love to travel. I like going to Europe, and one of my favorite places in the US is Alaska. Right, Brian? I'm also busy with Special Olympics. I am an athlete and a global messenger. And since January, I am a member of the Special Olympics Board of Directors. I have competed in swimming, cycling, and skiing. Actually, in January of 2013, I was in South Korea for the Special Olympics World Games. I competed in alpine skiing against girls from Germany, Austria, and Russia. They were tough, but so was I. I won a silver medal in the slalom. A global messenger is like an ambassador for Special Olympics. Through public speaking, we recruit athletes and sponsors and volunteers. I tell my audiences how very important Special Olympics is for people like me. I am also an inspirational speaker. I speak on behalf of other people with intellectual disabilities. My presentations help in building understanding for all people with disabilities. I tell them about the people I know with Down syndrome who are very accomplished. Some are painters, writers, and musicians. And some are even very famous, like Lauren Potter, the actress from the television show Glee. And then there are others like me. I'm just a regular girl with hopes and with dreams, just like yours. And now I'm going to show you a few slides. Only Virgin trained my whole family. Boy, they give me a real workout. And these are my personal trainers at home. These are my brothers and my sister, and they all love me. Waiting for that big bus. I took the regular classes, just like everyone. Oh, yeah. I rode the school bus, just like the other kids. High school was fun, but hard work. Yes. I took the regular classes together. I was included. And I also ran spring track and cross country for all 4 years. But the best part was graduating with the same kids that were in kindergarten with me. The transition program the transition program prepared me for a real job. This is my office in the State House. I work on the computer. I do the mail, and I also do the telephone, and many other things. And this is my boss, Senator Jamie Eldridge. I helped with his campaign, and now he's a senator. I get to meet. Being at the State House is fun, and I meet many I meet interesting people. It is fun and interesting. This is Governor Baker. He had to kneel while to take this picture with me. I love working with young children. And some of them have joined my Special Olympics ski team. They're so much fun. I have done many keynote presentations. Like in October, I was in Seattle for a big fundraiser. And in November, I gave the keynote speaking at the World Trade Center right here in Boston. Remember this time? I'm a member of this council. We help in many events, like this one, of course. This is our buddy walk. We give ideas to the board at the MDSC. And this is Anna Brown. She is a recording artist. And every year she comes and we love her. And actually she was on American Idol contestant from Massachusetts. Yes. This is at the kickoff for the Your Next Star campaign. This video shows people with Down syndrome in the workplace, and I am one of them. This is Michael Carr, our chief of staff, and Bob Sweeney. He is a Boston Bruins alumni, and he is also an employer. He also hired a young man with Down syndrome to work with him. And you can see this video on YouTube. I love Special Olympics. This is Mrs. Shriver. She founded Special Olympics in her own backyard. She was she's an amazing person, and she will always be my inspiration. Thanks to her, we have Special Olympics. I love skiing. I won a silver medal in Nagano in Japan, and again in South Korea. This is Tim Shriver. He's the chairman of Special Olympics. He gave me my medal in Japan, and he watched me win my silver medal in South Korea. Being in both of those places was an amazing time because that's where I was very honored to represent Team USA. These are some of the places that I have been, like kayaking in Alaska, Brian, with my brother on the Prince William Sound. And last summer, I was back in Holland all by myself, visiting my family and my friends. And I also love Italy, where my sister got married. And I'm a big fan of our Boston teams. Do you know who this is? Yes, you guessed it, Tom Brady. And these are my fans. These are my sister's 4 boys. And I have a new fan. This is my brother's wife's baby boy. Thank you for listening to my story.